Dr. Klaus Görlinger. His main specialty is anesthesiology, emergency, and intensive care medicine. And his subspecialty is hemostasis, pain therapy, and diving medicine. He's working in University Hospital Essen in Germany, in Munich. He obtained his medical degree in 1986 and then obtained emergency doctor since 1990. He became consultant for anesthesiology since 1991. Leading emergency doctor since January 95, consultant for intensive care medicine since January 96. He's also a consultant for diving medicine since December 2003. He's a consultant of hemostasis since August 2007, and he's a consultant for emergency medicine since 2007 also. He's a consultant for pain management since 2010, and now, sorry, he's a medical director in Munich, Germany since 2012 till today. His main field of research is the development and implementation of POC-guided algorithm for perioperative bleeding management and pain patient blood management. He has many publications, and he will talk to us today about perioperative blood management. Dr. Klaus.
So I think we can save the time here to repeat this again. It's of course the most important point for conflict of interest is that, as mentioned already, since 2012, I'm the global medical director of the TEM Innovations, the Rotem company. But I think I have also another conflict of interest, or what I just want to mention is that, of course, I would like to dedicate this presentation to the twin city of Munich, which is Kiev. And I think all the people in Kiev suffer a lot, actually, due to the war, and we should do everything to stop this war as soon as possible. Bringing us back to bleeding management, which is, of course, also an issue in military settings, but I will focus here on of course, civilian issues. And if we have a bleeding patient, the first question to ask is, why does my patient bleed? And we all know, of course, in particular in perioperative bleeding, there can be surgical bleeding. And an example is a picture on the left, where I always say when the blood comes up to the surgeon, to the face of the surgeon, it must be a surgical bleeding from a high pressure area. When we have the situation like on the right side, which we call the blood on floor syndrome, usually it's a combination of both, and the discussion between anesthesiologist and surgeon who is has to be blamed for the bleeding doesn't make any sense, because now, of course, we have to work closely together for the surgeon to stop surgical bleeding and for us as anesthesiologists to treat the coagulopathy adequately without also of overtreatment. And of course, the question is, what is the best way to fix this problem? And there's a traditional way is to activate a massive transfusion protocol, which means that if the patient is losing blood, we just replace the blood volume by transfusing and hope that somebody else will stop the bleed. So of course, in the beginning of a bleeding, that might be necessary, but in the end, it might not fix the problem. And therefore, I think we should move from massive transfusion protocols with a focus just to replace blood to massive hemorrhage protocols, because the aim is to stop the bleed and not just to replace blood. And finally, this ends in a massive transfusion avoiding protocol, because if we can stop the bleed as soon as possible, maybe we can avoid massive transfusion. And we all know that massive transfusion is not healthy for our patients. Of course, there are a lot of studies looking at the different concepts, and one of the most important studies for a ratio-based approach is a proper trial. It was a randomized trial in the US where they compared two different ratios for plasma, platelets, and red blood cells. In one group, 1:1:1, and in the second group 1:1:2, where 2 are the red blood cells. So that means in 1:1:1, you give twice the amount of plasma and platelets compared to the other group. And of course, the idea was if we give more blood products, we might stop bleeding earlier and also reduce mortality. Unfortunately, in this study, only 6-hour mortality could be reduced, where 24 hours and 30-day mortality was not significantly reduced. So that already reflects a little bit that if we give too much blood, maybe you have later on issues like multiple organ failure and other issues. What is the evidence behind? We know already since more than 10 years, and these are data from the UK SHOT report, Serious Hazards of Transfusion, and from the FDA, that nowadays, thanks to virus testing, which we do routinely in our blood donors, this is not anymore the main issue. The main issue is inappropriate use of blood. And that means that 2/3 of all transfusion-related mortality is based on transfusion-related acute lung injury, transfusion-associated circulatory overload, and transfusion-related immunomodulation with microinfection. And of course, you cannot test the blood for transfusion-associated circulatory overload. That's, again, it's the wrong use of blood and maybe over-transfusion. And when we look at several studies, and this is also, again, more than 10 years old, and you see here one of the authors was John Holcomb, the father of 1:1:1 in the US. They already showed 10 years ago, if we give plasma transfusion to patients who finally don't need a massive transfusion, there was no benefit but a substantial increase in complications. 12-fold increase in lung injury, 6-fold increase in multiple organ dysfunction, and 4-fold increase in pneumonia and sepsis. And when we go to other settings, here is acute variceal hemorrhage in cirrhotic patients. Just last year, a multi-center study was published looking at the effect of plasma transfusion in this setting. And plasma transfusion was associated with an increased odds of mortality at 42 days. It not just doubled. The odds rate was 9.4, so nearly 10-fold increase in mortality. And at the same time, an increase, nearly 4-fold increase in the failure to control bleeding at day 5, and it prolonged the length of stay. And the explanation for this is that we know that plasma is not very effective to treat a coagulopathy. However, it's very effective to increase the volume, and portal hypertension is the main reason for bleeding in cirrhotic patients. So it doesn't even help, but it has a significant increase in mortality. When we look at postpartum hemorrhage, another setting, there was also an interesting study 2 years ago published in JAMA, where they were looking at the effect of plasma transfusion in PPH if you give it within 1 hour, within 2 hours, and within 3 hours. And they were looking at a composite endpoint, which was a mortality, hysterectomy, or the need for arterial embolization. So if they give plasma within 60 minutes, there was a 50% increase in worse outcome. If you give plasma within 120 minutes, there's a 70% increase in worse outcome. And if you give plasma within 3 hours, there's a 150% increase in worse outcome. But there was no time point where there was a decrease in worse outcome, so an improvement in outcome. So again, plasma transfusion seems not to be effective to treat coagulopathy also in postpartum hemorrhage. And maybe at the last setting, going to cardiovascular surgery, where there is the highest evidence, because there was already in 2015 a meta-analysis done by the Cochrane group, including 15 randomized trials. And the result of this meta-analysis was that transfusion with fresh frozen plasma was inferior to control for preventing patients receiving any red blood cell transfusion with an odds ratio of 2.6. So again, there was more blood transfusion and not less blood transfusion. And again, the reason is, yes, Plasma transfusion, due to the low concentration of factors, in particular fibrinogen, is not effective to treat the coagulopathy, but it's very effective to dilute the hemoglobin level. So whatever cutoff you use for red blood cell transfusion, if it's 7, 8, or 9, you will reach it earlier with plasma transfusion. And this, in the end, results in more blood transfusion and not less blood transfusion. But it's, of course, not about blood transfusion. You know, in patient blood management, we are talking about patients' outcomes. And this is a quite interesting study who nicely shows also the link to the clinical outcome. That was a study where they implemented a ROTEM-guided approach, and they were looking what is the effect on transfusion requirements and outcomes. And what you see is that in the group after implementation of a goal-directed bleeding management protocol, plasma transfusion went down from more than 2 liters to less than 300 milliliters. Also, when we look at the incidence or frequency of plasma transfusion, it was nearly everybody before implementing the protocol is 97%, which drops down to 35%. But the most important point is that at the same time, pulmonary complications also went down from 83 to 44%. So before it was normal that they had pulmonary complications, and now it's less than 50%. And at the same time, that's just a side effect, there was a significant reduction in costs from nearly 1,300 euro to about 800 euro. So you get better outcomes with lower costs. So that's the reason why we are performing viscoelastic testing. It's an essential part of patient blood management, in particular, the second pillar. But again, this is, again, an essential part of patient safety. And that's not a new idea. Already 2,500 years ago, Hippocrates, more or less the father of all physicians, mentioned that, of course, physicians like to cure, but maybe more important is to avoid additional harm. And we also know that in the beginning of patient blood management, everything was focused on red blood cell transfusion, but more and more also the so-called yellow blood products, so plasma and platelets, gets into the focus, because even the yellow blood products are usually given just based on gut feeling, without well-defined clinical indications, and a more restrictive transfusion strategy might be very beneficial, because a lot of the nowadays most important issues like Charlie and TACO are more mediated by plasma than by red blood cells. And the goal in general of a goal-directed therapy is just give the right product at the right time to the right patient and in the right indications. And we should be, again, as restrictive as possible, in particular with products which never showed in any big study a beneficial effect. That doesn't mean that nobody needs it, but we should just identify the right patients and then give plasma to the patients who really need it. And that was the reason to develop algorithms, because we all know in the operation theater, not 24/7, there's an hemostasis expert. So what we try to do is take all the evidence available, and there's a lot of publications about goal-directed strategies, and then create protocols like flight checklists for different settings. Because we also know that the pathophysiology of bleeding is not the same in cardiovascular surgery or in livers or in trauma or in obstetrics. And we have to understand ROTEM algorithms as not to do algorithms. That means we all know a hemostasis test doesn't have a high positive predictive value. That is at best 25%. So we should not treat numbers. But in the algorithms, we use that very high negative predictive value, which is 90 to 97%. So step by step, we exclude reasons for bleeding. And if we don't find the coagulopathy, the chance is very high that this is just a surgical bleeding. And then they need a suture or a clip or a compression, but not a blood product. And of course, we can also adapt the protocol to the pediatric population. They have also some different cutoff values, but most important, we have to be much more precise in the dosing, of course, in a very small child. Time is very important. We know in severe bleeding, and that's a strong limitation of standard coagulation tests, which of course have their value, but usually they have a turnaround time of 45 to 60 minutes. And this is not acceptable in a severe bleeding. And we just finalized 2 years ago a small interventional study. It was more implementation study as a part of the big European Center TBI trial, looking at patients with traumatic brain injury. Sorry. And the main question was, if we implement this concept in an emergency department who never used viscoelastic testing before, how quick we can implement, how quick are the results available, and can we train them on a simple protocol, as I showed before, to make also the decision-making quicker, because a patient doesn't stop to bleed when we have the lab results, it stops to bleed when we do the right intervention. And what you see is that the time to result after blood sampling, and of course for standard lab as well as for ROTEM, we need a blood sample, it was just 15 minutes with a range from 10 to 20 minutes in the ROTEM Sigma group, where it was 40 minutes longer for the standard coagulation test. That's not new data. That's not a surprise. But maybe most important is that also the time to treat after results are available, avoiding that we now start a big discussion that we can follow a quite simple protocol. It was a little bit less than 10 minutes that the therapy was done. So it supports a quick but precise decision making. And why is this important? Going back to the proper trial, that was the 1-to-1 to 1-to-2. What is the important message also from this study is that every 15 minutes decrease in time to hemostasis was associated with a significant decrease in 30-day mortality. It's just 3%. And you might say, oh, 3%, that's nothing. But keep in mind that we were already 40 minutes quicker. So that's nearly 3 times 15 minutes. And if then also the therapy is done quicker, that may be the 4th time 15 minutes. And we are talking now about 12% reduction in mortality. And the same was true for the reduction in acute kidney injury, lung injury, multiple organ failure, and sepsis, without any increase in thromboembolic complications. So having results quicker available and doing decisions quicker, but based on evidence-based data and algorithms, seems to have definitely an advantage. I just go through some examples of the interpretation, how we can do this in a quite quick way. And when we look at thrombolysis, here we have just the XSTEM test, that's extrinsic activation, like the PT-INR, and the FIBTEM, where we knock out the platelets. So we can see what happens in these two extrinsically activated tests. So that's normal. Oh, sorry, wrong direction. And now we see here on the left side, which is called in the US the deadly diamond. So this is severe hyperthrombolysis. And you see the effect is even stronger on the FIBTEM. And of course, we have to treat these patients with tranexamic acid. But we also know even treating them with tranexamic acid means there's still an 80% chance to die, because of course we avoid hyperthrombolysis, but the reason for hyperthrombolysis is severe shock and tissue injury. So that means, of course, we have also to take care that we bring patient out of shock. And this is something which we focus even just in the last years. This is a so-called thrombolysis shutdown. That means less than 3.5% lysis within 1 hour. And that's what we see quite often in our critical ill COVID-19 patient. And this is associated with a very high rate of thromboembolic complications. Looking at clot firmness management, which is usually the second part of the algorithm. This is again the normal XSTEM and FIBTEM. What we see on the left side is a significant reduction in here, for example, the amplitude after 5 minutes. In XSTEM, it's even below 25 millimeters. For trauma, our trigger is 35. And we see that the FIBTEM clot firmness A5 is only 6 millimeters. Here, the cutoff for trauma would be 10. So we see that both are reduced. And if the patient is bleeding, we are sure that this is based on a low fibrin contribution, and fibrinogen or cryoprecipitate is the best intervention to treat this issue. On the right side, we have also a reduced clot firmness in extem, but the FIBTEM is very high, 15 millimeters. So we would be even happy in a postpartum hemorrhage. So that means if this patient is bleeding, additional fibrinogen will not work. So here we have to give platelets, and we can very quickly differentiate what is really needed. Of course, some patients also have an issue in thrombin generation, and here we are looking at the extrinsic and the intrinsic pathway, and we work here in both with tests which have a heparin inhibitor on board, because we don't want to see a heparin effect, which can also happen in severe trauma endogenously by damaging the glycocalyx. We want to see if they really affect the deficiency or there is an anticoagulant. And what we see in this case, there is a significant prolongation of the extem clotting time, where the intem clotting time did not change. And this is a typical pattern of a vitamin K antagonist like warfarin. And on the right side, we see there's a prolongation of both extrinsically time, much more even as in warfarin, and also of the intrinsic clotting time. That's a typical picture of a DOAC, because here we see there's something in the common pathway. So it must be factor 10 or factor 2. And here, for example, this is a dabigatran effect. And more, we also have to look at the other side of the coin, how it looks like when there is a hypercoagulability. This is again the normal temogram with extem and FIBTEM. And what we see here is a severe hypercoagulability. You see clot firmness in extem. MCF is even 78, and in FIBTEM it's 50. The good news here is there is still physiologic lysis. So that's a 7% in 1 hour. That's the good patients, for example, with COVID, because the cleaning system is still working. That's the worst situation, hypercoagulability and fibrolysis shutdown. And that's a patient who have very often thromboembolic complications with COVID. So what's the evidence behind, or how this affects also guidelines? These are the first update from the European Society of Anesthesiology guidelines on the management of severe preoperative bleeding, published in 2017. The next edition is just on the way, and there was already a recommendation to use standardized viscoelastic testing guided hemostatic algorithms with predefined intervention triggers with a 1B recommendation. Since there have been several new randomized trials and meta-analyses, we may even have in the next edition a 1A recommendation. This is even an older meta-analysis looking at clinical outcomes, focusing on cardiac patients, nearly 8,500 patients. And what we see is there is a significant reduction in acute kidney injury with a risk ratio of 0.77, thromboembolic events more than 50% reduced, re-expiration reduced, and any kind of transfusion, and not a big surprise, in particular of fresh frozen plasma. This is the latest meta-analysis from colleagues from Brazil, published in 2020. And you see now it's even 21 randomized trials and 8,900 patients. And when we look at the, of course, most important endpoint, mortality, we see when we look at tech studies, it's borderline, it's already going in the right direction. And the risk ratio is 0.71. When we look at ROTAM studies, it's already significant with a risk ratio of 0.48. That means more than 50% reduction in mortality. And even if we take both studies together, of course, we end up with a risk ratio between both groups with at least 0.64. Again, acute kidney injury is also an important endpoint. We see some trend, but not so strong already in the tech studies, but a highly significant reduction in the ROTEM studies, where the risk ratio of 0.49. I think that's not based on the device, that's based on the algorithms, because most tech algorithms starts with plasma and then with platelet transfusion, and ROTEM algorithms try to avoid plasma and platelet transfusion. So I think this is more based, again, on the algorithm. Why is this important? We know from studies who are looking at a long-term outcome, and of course this studies takes quite a lot of time, that acute kidney injury after cardiac surgery is associated with significant long-term outcome. And if we just look at the 5-year survival here, we see if we can avoid acute kidney injury, more than 90% of our cardiac patients survive the next 5 years, where when there is any acute kidney injury, this drops down to 70%. So that means if we cannot avoid acute kidney injury, 20% of our patients will not survive the next 5 years. And that's the difference between both groups. In between, also the US colleagues followed this concept. So in the 2019 published recommendations from the Society of Cardiovascular Anesthesiologists in the US, they also recommend viscoelastic testing and implementing algorithms, and even here display more or less a modified version of our algorithm. The same is true for trauma. Here in the 5th edition of the European Trauma Guidelines, they clearly recommend to use goal-directed strategies using viscoelastic testing with a 1B recommendation. And even there are more and more data, even from the military field. So this was published by a US group in 2020. It's based on 3,300 patients or soldiers from Afghanistan. And there was in mean a mortality of about 10%, because usually it's a young people. But they could show in the subgroup with viscoelastic testing for initial resuscitation that the mortality went down from 13.1 to 7.3. So this is an odds ratio for mortality of 0.6. So even in the military setting, there is a significant reduction in mortality. And also, the latest US guidelines published by the Eastern Association of Surgery of Trauma, within their guidelines, they also did a meta-analysis of 6 trials using viscoelastic testing in trauma. And what you see is, again, a risk ratio for mortality of 0.75. It's not the same as in cardiac surgery, but at least 25% reduction in mortality. However, that's not the only studies available. It's overall 22 studies looking at the effect of viscoelastic testing in severe trauma. 2 in the military setting. I already mentioned the biggest one. Overall, 3,500 patients with a risk ratio of 0.7. There are also 20 studies in the civilian setting with nearly 5,000 patients. You see the risk ratio is exactly the same between military and civilian trauma. So if we take all the studies together, nearly 8,500 patients, the risk ratio for mortality is 0.71 with a p-value of 0.001, so extremely high significance. And that has, at least in Europe, the effect that the concept of treating trauma patients in Europe more and more moves to the goal-directed strategy, which means we have to measure first, and then that we can do the intervention in the shortest time possible and in the most exact dosing. We use more and more pharmacologic interventions. So that means, of course, tranexamic acid to stop hyperthrombolysis, fibrinogen concentrate to increase the fibrinogen level if needed, and prothrombin complex concentrate to increase thrombin generation, which is not so often needed, in particular when we can stop the bleeding early. Usually we can avoid it, but in ongoing bleeding, that's sometimes also necessary. It's also true, of course, for obstetric hemorrhage, where the group from Cardiff in Wales with Peter Collins, Sarah Bell, and Rachel Collis did a lot of work and implemented in all obstetric units in Wales algorithms based on ROTEM, and you can use cryo or fibrinogen concentrate. But of course, this is embedded in an overall concept of bleeding management in postpartum hemorrhage, because still most patients are bleeding due to uterus atony. And we don't need blood products in uterus atony. Then we need a uterotonic drug, but we have to identify the reason for bleeding. What is the effect on outcome? So we see here, this is based on 2 studies, but overall 50,000 deliveries. One study was done at Yale University in the US and the other in Liverpool. And you see that hysterectomy rate could be reduced by 50% and the need for ICU admission by more than 85% as just a surrogate parameter of less complication rates. So what's about mortality as the most important outcome? And we see here first the woman trial, you know, that was a study, 20,000 patients, tranexamic acid or not, mainly done in developing countries. And you see overall mortality was reduced from 2.6 to 2.3%, and mortality due to bleeding from 1.9 to 1.5%, which was borderline significant. The issue is if you do studies in experienced centers like Yale, Liverpool, or also in Cardiff in Wales, there was no mortality. And then it's difficult to reduce zero mortality. And that's the reason why we're using these surrogate parameters like hysterectomy rate, which was not reduced in the woman trial, and ICU admission rate was not reported, but we see very good trends here, or not only trends, highly significant changes in the complication rates. So to summarize, I think there's also just last year published a policy brief from the WHO, and that there is an urgent need to implement patient blood management around the world, not just to save blood products, which are a precious resource, but also to improve patients' outcome. And if we have bleeding, we should keep calm, we should measure, but we need the results in a short time. And then we should do the right intervention to stop bleeding, but also to avoid overtreatment, and by this also to avoid thrombosis. On the other hand, I think we should not keep calm when it's the point to stop war. And I thank you for your attention and open for questions.